Dear doctors, this topic is very, very vital for our diabetic management. If you ask me a leading question that which is the costliest complication of the diabetes, I say it is the diabetic foot. It is not the diabetic kidney disease or an ischemic heart disease or an heart failure, etc. Even though the stent costs about 1.5 lakh, even they put 1 or 2 stents or 3 stents, it will hardly cost for about 3 to 4 lakhs. But for a diabetic foot, for proper management of the diabetic foot, the money you expend on the surgical debridements or the antibiotics or repeated dressings and repeated consultations and then the repeated investigations and the bed rest, hospital stay, if you combine all these things, some of my patients, the total amount may be more than the 10 lakhs also to save the limb. Otherwise, most of these people are going to have amputation. So if you see an amputated fellow on the road in any Indian subcontinent, there were only two reasons. One is a traumatic amputation. The second one is the diabetic foot amputation. So with this background, so don't underestimate the importance of the diabetic foot in our learning. This is one of the important subtopics to be covered in this subject. If you see the magnitude of the problem, 15% of all patients with diabetes sometime in their lives. It depends on the areas also. If the persons are from the rural India, most of the rural India, they might be having maybe 20 to 25% also because of the barefoot walking, because of the more prone to get the injuries. Prevalence of the active foot ulceration varies from 1% in the Europe and North America to more than 10% in Africa, maybe in India, maybe 12 to 15% in India. Incidence of the foot ulcers in diabetes is approximately 2% per annum. If you see the diabetic population in India, so recent ICMR India study, 10.3 crores, that is December 2022 statistics. So if you add few more, maybe 12 crores by this time. So the diabetic individuals in India, nearly the 12 crores of the type 2 diabetics. Even the 2%, it's a very, very big number as far as the diabetic foot is concerned. The foot problems account for 25 to 50% of all hospitalizations in patients with the diabetes. I think it is an exaggeration, not more 25 to 50% of all hospitalizations in patients with diabetes. Nowadays, no hospitalization indications for the diabetes are mostly the sepsis, mostly the pneumonias, or maybe the surgical indications, etc. Not the diabetic foot alone, 25 to 50, maybe 15 to 20%. Diabetes is the leading cause of non-traumatic lower limb amputation in the world and also in India. Globally, over 1 million lower limbs are lost due to the diabetes annually. Every 30 seconds, a lower limb is lost somewhere in the world due to diabetes, especially in India, especially in our South India, especially in our Andhra Pradesh, because of the excess alcoholism and because of the rash driving, because of the no helmet, no seat belt rules. So these are all the reasons to have the diabetic foot ulcers here. So rough estimates indicate that in India over 1 lakh lower limbs are lost due to the diabetes annually. 75% of these amputations are in the neuropathic feet with secondary infections which are potentially preventable. See, the diabetic foot problem is a preventable problem. So the foot care is very, very important in all the diabetic individuals. So not only the neuropathic feet, there could be also a vasculopathic feet. So the three reasons to cause the diabetic foot is infection is the very, very important, and then the vasculopathy and the neuropathy. So I will at the latter time I will tell you what you mean by the neuropathic foot and the vasculopathic foot, etc. So these are all the predisposing factors for the foot ulcerations. Large and small vessel disease, that is your vasculopathy. Susceptibility to the infection, so more and more infection, maybe paronychia or a small abrasions or barefoot walking, etc. Chronic sensory and the motor neuropathy, a part of the neuropathy. Autonomic neuropathy leading to the dryness of the skin. This is also very important, elderly and a chronic diabetics. So not only your sensory neuropathy or motor neuropathy, there could be autonomic neuropathy also. And then the local deformity. Some people will have the hammer toes. Okay, these are the some of the local deformities. We are more prone for the foot ulcerations. It may be the callus formations. So they get injured and then get infected. So leads to the foot ulcerations. So if you see this chart, the four important reasons here are neuropathy, not only your sensory and motor, and also the autonomic neuropathy and the vasculopathy Need not be always the large vessel vasculopathy, maybe the small vessel vasculopathy also, and then the infections, and then maybe the local deformity in some foods. So finally, they lead to the ulceration, and then left untreated here. So definitely they need an amputation also. Not only the amputation of the amputation of the toe, or an amputation of the forefoot, the amputation of the total foot, or below knee amputation, above knee amputation, and total lower limb amputation. They are all possible in all the diabetic individuals. And don't think that only lower limbs, maybe the upper limbs also. I have the 3 people who lost their hands because of the diabetic infections. Simple one fellow, simple started with the paranoia, and then they lost the total limb because of the ignorance. Neuropathy leads to the lack of the protective sensations in innate foot, leads to the injuries that remain unnoticed for a long time because of the anesthesia or paresthesia or hyposthesia. Motor neuropathy can cause loss of the power of the muscles of the thighs, legs, and the feet. So these people, they can't stand up from the sitting position. So that is your proximal motor neuropathy, leading to the development of the hammer toes, bunions, and other foot deformities. So in order to maintain their gait, in order to walk properly, so they keep lot of the pressure on the toes. So the toes become the hammer toes or the bunions, etc. Deformities lead to the development of the abnormal pressure points over the foot, where the calluses can develop. So you all appreciate, lot of the people will have the few calluses on the sole of the foot, and can also predispose to the development of the Charcot foot. So Charcot foot is another very big problem in a diabetic. Auto digestion of the bones. If you take an X-ray of the foot, all the small bones are digested, auto digest. Like your systemic sclerosis, there is the auto digestion of the toes. Fingers, tips of the fingers. The same thing happens here in the Charcot foot. So auto digestion of the small bones of the foot leading to the Charcot foot. It could be acute Charcot foot or a chronic Charcot foot. So here also there will be the long casting cash. Then these are very important. Autonomic neuropathy leads to the reduced sweating, dryness of the skin, and the fissuring. Can lead to the microvascular dysfunction, the AV shunting, with reduced perfusion to the areas in the knee. See, the callus developed due to the repetitive mechanical forces of gait is due to the pressure from the ill-fitting footwear. So these calluses are the potential reasons to have a diabetic foot ulcer, and then naturally, so if left untreated, maybe the first grade 2 amputations, and then finally lot of the cellulitis and etc. So develop only if the blood flow is adequate. Thick callus can press on underlying soft tissue and cause ulceration. Callus is not removed in the time. Tissue necrosis occurs, leading to the formation of a neuropathic ulcer, that is a trophic ulcer. See, these are all the neuropathic ulcers, mostly on the pressure points. Ulcer in the neuropathic foot develop at the pressure points. Sensory neuropathy, toe ulcer. Sensory neuropathy, erosions on the dorsum of the foot. See the bones there, toes there, almost looks like early hammer toes. So a lot of the pressure on the tips of the toes. Deformities found in the neuropathic foot, claw toes, hammer toes. So these are all because of the pressure points. So they get injured and ulcerated. See the appreciation of the veins there. Distended veins on the dorsum of the foot of a patient with diabetes and autonomic neuropathy. Charcot neuroarthropathy is a relatively painless, a progressive and degenerative arthropathy. Single or the multiple joints caused by an underlying neurological defect. Relatively uncommon complication of the diabetes. Prevalence 0.08 to 13%. Found in both type 1 and the type 2 of long duration. Chronic diabetics. Usually unilateral, but sometimes a bilateral in 1/4 of the cases. Occurs in individuals with the diabetic duration more than the 12 years. See, the 12 years or 10 years, 8 years depends on your control of the diabetes. Okay, if the diabetes is under control, if they maintain the HbA1c around 6.5 or less than 7, maybe even after 25 years or 30 years of also, they may not develop the Charcot foot. On the other hand, with a 5 years history of the diabetes with uncontrolled and lot of the hammer toes, pressure points, etc., so they may develop these Charcot foots also. So if you see the pathogenesis here, both the neurotraumatic and the neurovascular, it is the sensory motor neuropathy and autonomic neuropathy, both are involved here. So in sensory motor neuropathy, there is the proprioception, pain, vibration, intrinsic atrophy, choroidal atrophy, and equinus. In autonomic neuropathy, sympathetic failure, increased flow, AV shunting. So all these will lead to the instability and high risk foot. On the other hand, autonomic neuropathy, osteolysis, osteopenia, and bone atrophy. And some trauma, so definitely there will be the spontaneous dislocation, neuropathic fractures, osteoarthropathy. So it is a big vicious cycle. So in the to cause the charcot foot, so both the sensory, motor, and autonomic, and also some trauma are involved here. As I told you, it could be acute or the chronic. In acute stage, it is a hot, swollen, erythematous foot. Bone crepitus will be positive sometimes. Pain conspicuous by its mildness and the absence. Patient may recall the minor trauma in the preceding days or the weeks. Some people, they may not recognize also trauma. Calmness site midfoot followed by the metatarsophalangeal joints and ankle joints. In the chronic, a patient presents with the various deformities, including the flat foot, rocker bottom foot. Usually the vascular of the foot will be good and pulses may be the bounding. So that is a big point against your vasculopathies, vascular foot ulcers. In vasculopathy, so you expect diminished pulsations there or absent pulses. Okay, that is because of the peripheral vascular disease. So some thrombus in the anterior peroneal artery or posterior peroneal artery or in the popliteal arteries, etc. So there will be the foot will be the calm. Here this is the acute left upper because of the hot, swollen, erythematous, and the lower one could be the chronic, and see the fractures. So without noticing that, that fellow is walking even with the fractures because of the painless foot. So after some years, so if you see the X-ray, almost total absorption of these joints. We discussed the peripheral arterial disease when we discussed the macrovascular complications, the coronary artery disease or peripheral vascular disease and cerebrovascular disease. The same thing here. It is due to the atherosclerotic occlusion of the lower limb arteries, decreased delivery of the oxygen and the nutrients required for the normal function, gives history of the intermittent claudication. That is the most important point in peripheral arterial disease, intermittent claudication. Rest pain may indicate the critical ischemia. Symptom of intermittent claudication may be absent if there is a concomitant sensory neuropathy. Loss of hair, atrophy of the skin and the nails may be seen. Poor healing of the foot injuries, infections or ulceration can lead to the necrosis and then the gangrene. See, this is the ischemic foot. So the gangrene of the third toe there, and here in the second picture top right, second toe gangrene. Last picture, second toe, third, fourth, fifth, and see the pigmentation there. So this is because of the lack of oxygen supply there. So because of the vasculopathy, so there are a lot of the pigmentation and etc. So these are we are often see such cases in our routine practice. So here you have to use the drugs which improve the vasculature like your aspirin or clopidogrel or stelastazole, stelaz, or then the atorvastatin maybe 40 milligrams or rosuvastatin 20 milligrams. So these are all the standard drugs we prescribe for the vasculopathy part, and for the neuropathic part you can use the methylcobalamin or gabapentin or pregabalin or nortriptyline, amitriptyline, etc. But most of the people, they develop some nausea, vomiting, giddiness, vertigo, pedal edema, so irritability. So all these are very common side effects of your pregabalin and the gabapentin. So whenever you want to use these pregabalin or gabapentin, start with the low dose, maybe 50 milligrams of pregabalin instead of the 75 milligrams or 150 milligrams of the pregabalin. Okay, so that is slowly uptitrate the dosages. Otherwise, these people will have a pedal edema. Sometimes I have seen one a doctor's wife presented with pedal edema, bilateral pedal edema. So when I look into the history part and the medication, she was started on the pregabalin for the last 1 week, and she developed pedal edema for the last 3 days. So worrying about it could be CKD or it could be IHD or it could be heart failure or it could be chronic liver failure or anemia, hypoproteinemia. So these are all the common DDs we hear. Then I told him stop pregabalin and review after 1 week. No medications. So she left. She felt very comfortable, and pedal edema was stopped because of the stoppage of your pregabalin. So these are the very common side effects we often see. The same thing happens with amlodipine also. Okay, so you all know that amlodipine will cause the pedal edema, but very few people know that pregabalin also will cause the pedal edema. Okay, so in the same way, some people they may present with the restlessness or sleeplessness. Okay, or early morning headaches. So there are whenever you prescribe any drug, you please see the side effects of these drugs. So the do's and don'ts of the drug, that is very, very important to practice in our practical diabetology. Okay, whatever the drug you take it, every drug will have few side effects. So suppose if you want to use the pioglitazone, same pioglitazone also will cause pedal edema, will increase the body weight. So some of my patient know, she has been taking the pioglitazone for the last 3 years and gained weight more than the 12 kgs. So the 12 kgs weight gain is because of the pioglitazone. Once you stop using the pioglitazone, and obviously the weight gain also will stop. And if the patient is on good aggressive exercise program, etc., definitely the excess weight gain will also be lost in another 3 months or 6 months. So some drugs will cause few side effects which are very, very common in our routine practice. In the same way, your sulfurias. Some people they develop the rash. Some people they develop the itching after starting your sulfurias. So whatever levocetirizine or desloratadine, etc. So they are only the partial relief. Unless you stop using the sulfurias, that allergic manifestations will not stop. But it's very, very difficult to stop sulfurias in those people who are accustomed to it because they are the very cheap and very potent hypoglycemic agents. Once you stop 2 milligrams of the glimepiride, so you have to use at least 2 to 3 other molecules to compensate for that hypoglycemic effect. So these are very fundamental and the practical points one should know about all the drugs, positives and negatives of the drugs, and then choose and combine accordingly. So this such type of the foods now, please accept such foods and think that what could be the reason, whether it is mostly the neuropathic or mostly the vasculopathic. And unfortunately in India, most are mixed. No, not 100% neuropathic, not 100% vascular. Mostly the mixed. So in that mixed combination, which one is predominant? Whether it is a neuropathic predominant or vasculopathic predominant, then act accordingly. See, as I told you, these two are the differences between the neuropathic and the ischemic ulcers. See the site of the ulcer, the pressure points and bony prominences for the neuropathic ulcers. Usually on the dorsum and the tip of the toes or between the toes is the ischemic. Okay. So at the pressure points and bony prominences, it is a neuropathic ulcer. And tip of the toe or on the dorsum of the foot, it is of the ischemic. Whereas the sole, mostly the neuropathic because of the pressure effects. Pain, neuropathic usually nocturnal pain and ischemic claudication pain may be present initially, later the rest pain is also possible. Blisters are very common in neuropathic, very rare in the ischemic. Deformities are common in neuropathic and deformities are rare in the ischemic. Here the deformities in the neuropathic is because of the motor neuropathy. Prognosis heals faster neuropathic because good vasculature is there, whereas ischemic heals slowly, may lead to the gangrene if neglected. So especially the ulcers on the dorsum of the foot, ulcers on the tips of the toes, or ulcers between the toes, mostly the ischemic. So be careful. So otherwise they heal very, very slowly and left untreated. So gangrene formation will be very high. Pulses will be present in neuropathy, obvious, absent or feeble in ischemic. Temperature of the foot is warm in neuropathic, cold in ischemic. Treatment pressure redistribution, here the revascularization. So some people they require the Doppler study, some people they require the peripheral angio in the ischemic ulcers, and then they put the 1 or 2 stents also if the lesion is very small. Otherwise they go for the bypass surgeries also in ischemic ulcers. So now the vascular surgeons are also available. Kakinada we have one vascular surgeon, Rajahmundry we have one vascular surgeon. So earlier no, to send these cases, so we have to send it for the Hyderabad or to the CMC Vellore or Chennai. Now everywhere there are vascular surgeons, we can use the expertization of these surgeons. But results are not that good because of the extensive disease in the diabetic individuals. In India, the majority of the foot ulcers are the neuropathic in origin. I say that it is mixed in origin. So both the neuropathic and the vasculopathic. Comparison of the features of the neuropathic and ischemic. See the neuropathic ulcers on the that one because of the pressure points. See the down one, that could be also the neuropathic because of the pressure areas. See the right picture, it is on the toe. So it is on the dorsum of the foot, mostly the vascular ulcer. So in the first two also the pulses will be well felt. Here the pulses may be feeble or the absent. Here the warm, there the skin is cold. Here no history of the intermittent claudication. In the next picture it could be the history of the claudication is also there. So these are very important. Precipitating factors, barefoot walking predisposes to the mechanical and the thermal injuries, shoe bite from ill-fitting footwear, home surgery for corns and the calluses, improper cutting of the nails, insect or the rodent bites, and other precipitating cause. Anyone can tell in this season. Other big precipitating factor: black dress, red dress, yellow dress, white dress. So white dress is for red for Bhavani Mala, black for Ayyappa Mala, okay, white Anjaneyar Mala. Okay. See, the most important thing here is these people are barefoot for about 15 days, 21 days, 40 days. And some of these people are the diabetics. So in every season, all the diabetics, I think at least 20 to 25% of the chronic diabetics, so definitely they suffer with some ulcers here. So this is a very, very important precipitating factor, especially our South India. So the number one factor here is the malas. Evaluation of the foot, foot examination, a general appearance, monofilament, ankle jerks, vibration sense. All my patients who wish to join in this Ayappa, Jatra, etc. And so I always advise them at least use the black chappals. But no one listens our word because Guru Swami doesn't agree for the black chappals. So I think definitely a day will come where all these people will wear the black chappals. Foot examination, because very, very important. Barefoot walking is an important precipitating factor. See the number one factor here is the barefoot walking. Barefoot walking. Okay, foot examination, the general appearance is very, very important. So some fellows will say that no, foot is much more important than the face in a chronic diabetic individuals. So they are very, very big foot specialists in India. Maybe Vijay Viswanathan. You have had Viswanathan Institute. He is having the 3 children. One female, one daughter and 2 sons. Both the sons are the diabetologists and son-in-law is also a diabetologist. Mohan Diabetes Center. Dr. Mohan is the elder son, Vijay is the second son, and son-in-law is the Ramchandran. All the 3 are Padma Shri awardee, very, very big figures in the diabetology. So all these 3 are practicing in Chennai and everyone is having more than 50 branches all over the world. So the top family. So in that, Vijay Viswanathan is very much interested in the foot care. Okay. So general appearance, a monofilament, ankle jerk, vibration sense. These are all things I have already told you when I dealt with the diabetic neuropathies. So 10 grams monofilament. Okay, vibration sense, 128 eggs. Ankle jerk with your this one. See, there's an illustration of the ankle jerk. So loss of the ankle jerk is very possible here, and vibrations are tuning fork. So that will be also disturbed, reduced. So this is a monofilament, 10 grams monofilament test. So most of the people, they may not appreciate this monofilament sensation. So those foods are at high risk of getting the injuries. So we have to see these foods. In all the diabetic individuals, please assess that before they develop the diabetic foot, you assess that your foot is at risk. So that is the most important. So that because it is a preventable one, it's a preventable disease. See the probe entering into the depth. A gritty feel to the base of the ulcer suggests the osteomyelitis. Almost the ulcer touches the bone there. So it's a chronic osteomyelitis. It's very, very difficult to heal them. So you have to use a lot of the antibiotics for a chronic period. And I think in a poorest of the poor individual, I think the amputation of the toe is much more better rather than the using the lot of the antibiotics and the chronic dressings. So sometimes I say straight away go for the foot amputation. they may not agree with us. On the day 1 and the day 2, when I see a bad diabetic food in a very poorest of the poor individual, I advise them go for the amputation. That will be much cheaper. Maybe 50,000 or 1 lakh. No one agrees that. So definitely they go for the lot of the infection. Finally, after 1 year, the 2 years, so the total cost will be that much. So they are very, very important here. The probe test. So to know the depth of the ulcer, whether it touches the bone or the not. So you will have a gritty feel. Investigations the diabetic foot to see the metabolic status. So your fasting blood sugar, PP blood sugar, HbA1c, total hemoglobin, complete blood picture. So hemoglobin, total blood counts. Okay, your polymorphs, your lymphocytes, your eosinophils, ESR. So these are all very important. And then of course urine and creatinine to rule out your renal functions. And more urea, more creatinine. So definitely poor healing because of the associated CKD. Electrolytes are very important. LFT. Not only that, the thyroid profiles, liver profiles, lipid profile, they are also important. X-ray foot is very, very important to rule out any osteomyelitis or any Charcot's foots or any fractures, etc. First, culture and sensitivity. So always we start one empirical antibiotic, maybe your amoxicillin clavulanic acid or maybe the ofloxacin with metronidazole, etc. But definitely the first culture will help you a lot because it identifies the organism and also gives you the sensitive antibiotic. So the peripheral Doppler, if you suspecting the vascular ulcers, otherwise, in every case you can go for the peripheral Doppler also because maybe asymptomatic or some people. Some people they may not give you a history of the intermediate claudication also. But still, I think the peripheral Doppler for all your diabetic foods is an advisable. And angiography in some cases. So this is how we have to investigate the diabetic foot. See, this is the Doppler ankle brachial index. Normal should be less than 0.9. And depending on your ABI, ankle brachial index, so you can divide this into mild, moderate, and the severe. If less than the 0.4, very severe critical stenosis, and they have subject for the amputation. So 0.4 to maybe 7 or 0.4 to 6, it is a very severe. No. Severe is less than 0.4. Moderate is 4 to 0.75. 0.75 to 0.9 is the mild. So that is the right answer. So less than the 9.9 is suggest for the peripheral arterial disease. 0.75 to 0.9 is the mild peripheral arterial disease. 0.4 to 0.75 is the moderate peripheral arterial disease. Less than 0.4 is a critical peripheral arterial disease where the amputation is the only answer. See, this is the biopsyometer. The radiology, diabetic osteomyelitis, the Charcot's foot. See the Charcot's foot. So you are not able to appreciate any bones there. So autodigestion of the bones there. See, you have the neuropathic foot and the neuroischemic foot. A warm, well-perfused foot with the bounding pulses, distended veins, callus can be seen, deformities, clatos, prone to Charcot's arthropathy, develop the necrosis if severe infections occurs. That is the neuropathy. In neuroischemic, a cool, pulseless foot with poor perfusion. Usually neuropathy coexists, can readily develop the necrosis. Plantar ulcers are the very rare. These ulcers are mostly on the dorsum of the foot or the tip of the toes. Ulcers develop at the edges of the foot also. A female, 48 years, diabetes for the last 12 years, injured her left leg 15 days ago, complaints of the pain and swelling of the left foot. She is not able to feel the monofilament or the vibration with 120 Hz tuning fork. Ankle jerk is absent. Both dorsalis pedis and posterior tibial pulses are absent. So what is your diagnosis? Ischemic, vascular. Patient has deep ulceration with infection and osteomyelitis on the plantar surface of the left foot. So it's a very critical case because on one hand you have these things, on the other hand the patient is a diabetic of 12 years duration. Okay, the chronic diabetes. So you get all the investigations and then assess their control of the blood sugars and then the infections. So send them first for the culture and sensitivity also because she is in severe infection and osteomyelitis is also there. Staging of the diabetic foot. Stage 1 is a normal foot. Features no risk, no symptoms. Foot examination is normal. But only 10 to 15% of our diabetes comes in this group. Normal foot. High risk foot, about 50 to 60% of our diabetics. Risk factors are present like smoking or barefoot, etc. No ulceration. Past history of the ulceration is a very high risk. So the common cause of the diabetic foot ulcer is history of the past diabetic foot infections. So these foot infections recurrence of the foot ulcers is very, very common. So past history of the ulceration is a high risk foot. Ulcerated foot, skin breakdown present, ulcer, blister or pressure. Infected foot, the purulent discharge or the cellulitis. Necrotic, so necrosis due to ischemia or severe infection. Also, unsalvable foot cannot be saved and needs the major amputation. So stage 3 and above need the referral to a foot clinic to a multidisciplinary approach. Here the surgeons, radiologists, etc. They may need we may need their expertise here. But as long as the 1 and 2 is concerned, so this includes about 90% of diabetic foots. Looks like the normal foot or the high risk foot. So these two are very, very important because we have to prevent ulceration, infection, necrosis, and then the amputation in these individuals. This is the Meggitt-Wagner's classification. So grade 0 foot at high risk but no ulceration. Grade 1 superficial ulceration. Grade 2 deep ulceration. Grade 3 deep ulceration with infection and osteomyelitis. 4 foot or localized gangrene. Extensive gangrene requiring the amputation. So if you see our general public coming to you for your consultation, most in the grade 3, 4 and 5. So by the time they approach the doctor, maybe extensive gangrene or a localized gangrene or the deep ulceration with infection and osteomyelitis, and there very little can be done. But grade 0, 1 and 2, so definitely 100% recovery is guaranteed. But unfortunately, because of the native medications and etc., they apply all these things in the grade 1 and 2, and finally they'll end up at the stage 4. So that is the reason when you are practicing the diabetology, so whenever a patient approaches to you after 5th visit or the 6th visit or 7th visit, that clearly shows that you have a good relation with that patient. So in those patients, even though their foot is normal, so you have to talk on the foot care. So your foot is at risk, or your foot is a normal foot. So ulceration, necrosis, gangrene, everything you should tell, you should talk to the patient. This is very, very important. See, finally the patient education is the most important part. So see, this is you earn as much money as possible, provided if the patient is with you only. Suppose if the patient develops a complication, then they approaches us. If the patient develops some ischemic heart disease, then he approaches to the cardiologist's hands. If the patient develops some CKD, then he goes to the nephrologist. So our aim is, so don't involve or don't get any complications in our own patients. So a diabetic should live as a diabetic till his death. He should not be converted as a complicated diabetes. Diabetes with the complication. That is possible, provided if you keep the HbA1c around 6.5 to 7. If you allow the patient above 9 or 10 or 11, so obviously you are inviting the complications. Once the patient gets the complications, definitely goes to that particular super specialist. Am I clear? So don't see hurriedly in any diabetic individuals. So take your own time, talk to them. Okay, tell all the importance of these laboratory investigations, and then get these investigations as and when required, depending on the patient's pocket. In some patients, no, I get HbA1c once in 3 months. On the other hand, in some patients, I get HbA1c once in a year. In some patients, I get all these investigations once in 6 months. In some patients, I may get maybe once in 2 years or once in 3 years also. So that depends on the patient's pocket and the economical condition. But one thing is very clear, that unless you know all these things, so you are not able to deliver the goods to our patients. So that is very, very important. So the foot care is very, very important. If you talk on the foot care, and other people also, they like you. Suppose if they get the infection after 1 year or 2 years, my doctor has told 2 years ago about my foot care, but I neglected. So he should realize that. and then he will come at even at the stage 1 and the stage 2. Otherwise, no, if you don't talk anything about the diabetic foot care, and definitely this fellow approach at you grade 4 or the grade 5. So this is the University of the Texas classification stage of the ulcer. You need not remember all these things, that there are different classifications. They say stage A, no infection or ischemia, maybe less than 5% of diabetic foots. Stage B, infection present, yes. Ischemia present, good. Both infection and ischemia present in stage 4. So most of our people, by the time they approach you, both infection and ischemia. In the same way, grade of the ulcers. Epithelialized wound, superficial wound, wound penetrating to the tendon or the capsule, wound penetrating the bone or the joint. So those are also very common here. So the multidisciplinary approach is required for the foot care because the causes for the foot complications are multifactorial. Sometimes, you have to act as a multidisciplinary doctor. Okay, so you are a diabetologist to that particular person, you are going to be a surgeon or an orthopedic surgeon or a radiologist, etc., etc. For some of your patients who cannot afford a multidisciplinary approach. So you are the team leader, podiatrist, so you should also act as a podiatrist. Interventional radiologist, we can send to the investigation for a radiologist there. Orthotist, general surgeon, vascular surgeon, orthopedic surgeon, and finally the educator. So the most important here are your diabetologist and educator and the podiatrist. These three can be done by you. Principles under diabetes of the foot management: a normal foot, prevent the development of the risk factors. What are all the risk factors for the foot ulcers? So your neuropathy, your vasculopathy, your infections, your deformities, etc. So glycemic control is very, very important. Lipid control is also important, and good foot care practices. High risk foot, proper footwear. This is very, very important. So customized footwear. Shadowpathy for cons and the callus, metabolic control, patient education, good footwear practices. Here a 60-year-old female, diabetes of 20 years, painless swelling of the ankle joint with the bounding of the peripheral pulses. So the bounding of the peripheral pulses, autonomic dysfunction, autonomic neuropathy. See the X-ray, autodigestion of the toes. So this is Charcot's orthopathy. Is it acute or chronic? Chronic, because it is a painless swelling. Painless swelling. It is painful and erythematous. It is acute. So immobilization, total contact cast, diabetic, walker, stress reduction, non-weight bearing, partial weight bearing with the crutches and the walkers. IV biphosphonates have been shown to help to reduce the pain and inflammation in the Charcot foot. Recent trials have shown the equivocal results. A chronic stage, orthotic management with footwear and insoles. Recurrent ulceration with fixed deformity indicates the need for the surgery. Surgery is contraindicated in the acute Charcot foot. Approach to the ulcerated foot, a neuropathic or neuroischemic ulcer. Offloading, that is a very, very important. So offloading is very important here. So surgical interventions, regular dressings, special footwear, foot care education, and then this. See here the angiogram. So there the SF here, there is a narrowing of the vessel there, the stenosis. So depending on the length of this stenosis, they put stents there, vascular interventions. So after the interventions, again the flow is regained. It is a revascularization. So subplantar abscess and the deep calcaneal lesions, angio multiple crural lesions, popliteal bypass, healing after the revascularization. See the skin graft. A chronic extensive ulcers may be healed by the skin grafts. Management of the infected foot, a microbiological control, a wound control, vascular control, mechanical control, metabolic control. So offloading is very important, antibiotics important, culturing sensitivity is important, and then your vascular medications and neuropathic medications and diabetic medications. Very simple. Antibiotics for the diabetic foot should be tailor-made based on the severity of the tissue damage and integrate the vascular supply and culture results. Do not wait for the cultures to start the antibiotics. You have to immediately start the empirical antibiotics here. A classic signs of infection may be masked by the presence of vascular disease or the neuropathy. Untreated infections can progress very rapidly and may lead to the loss of the limb or even the life also. Maybe sepsis, septicemia in all the uncontrolled diabetic individuals. Hence, empirical antibiotic therapy is indicated in a significant proportion of the diabetic foot ulcers. Empirical antibiotics for the diabetic foot. See the non-limb threatening, limb threatening, life threatening. So they divide into three groups. See in non-limb threatening, a simple ulcer, a simple necrosis, or a simple gangrene, where amoxicillin clavulanic acid, metronidazole, or ofloxacin metronidazole, or cephalosporins plus metronidazole are sufficient. So initially you can use the ceftriaxone, or you can use the amikacin, or your metronidazole, etc. And limb threatening, so you have to go for the like the ceftriaxone plus amikacin plus metronidazole, or tazobact plus amikacin plus metronidazole. And you respect the renal function here. When the creatinine is more than 1.2 or 1.3, better not to use the amikacin. There you can use the ciprofloxacin in the place of amikacin, which can also act against the gram-negative organisms. So quinolines you can add there. So always respect the renal function whenever you use the amikacin or any aminoglycosides. Ofloxacin is a very good drug. Metronidazole is a good combination. Cefoperazone, that is your magnemycin. Sulbactam, metronidazole, amikacin. So here you see any of these choices, they are the three drugs. One drug to cover the gram-positive organisms like your ampicillin or your cephalosporins. One drug to conquer your gram-negative organisms like your amikacin or gentamicin or ciprofloxacin or ofloxacin, and then anaerobic organisms, metronidazole. So that's how you have to combine the antibiotics in these threatening conditions, any sepsis in a diabetic individuals. So use gram-positive, gram-negative, and anaerobic organisms. And life-threatening, okay, you can go up to the meropenem, imipenem, tizicycline, etc. See the simple one, a non-limb or life-threatening, a superficial infections here. The ulcer is healthy, good, shallow ulcer without any purulence, complaint with a good support system, metabolically stable. Here, the best medication is control the blood pressures, control the blood sugars, control the lipids, and give a simple antibiotics here. You don't require any tazobact or meropenem, etc. here. Here the limb or the life-threatening see ulceration to the deep tissues, purulent discharge, big cellulitis, systemic toxicity, local necrosis or gangrene, osteomyelitis, metabolic instability, the poor compliance, lack of support system. See no granulation in these ulcers. All are white, no redness. Redness is your granulations. So here because of the poor vascular supply, because of the neuropathy, because of the local gangrenes, here it looks like a very small, but they are like limb threatening. So here you have to go for the higher antibiotics. See the osteomyelitis. This is the very important for your Charcot's foods and the chronic diabetic foot ulcers. Offloading is a very important. So the most important aspect in the healing of the neuropathic plantar ulcers is the offloading. So this is a very important. So this can be achieved using the total contact cast or the removable cast walkers. See the total contact cast, removable cast walkers. So these are very useful for the chronic diabetic foot ulcers. Otherwise, no. So again, if you don't use these things, again because of the pressure effects, again they develop the diabetic foot ulcers. Here again, female 64 years, admitted with history of ulcer, discharging the pus from big toe, swelling of the right foot, so that means the cellulitis, leg, so the cellulitis also extended to the legs, and also fever of the 1 week duration, so sepsis. She has had type 2 diabetes for 15 years and is on OHS. So how to treat? Stop OHA. Stop OHA, start insulin. because ulcer, discharging the pus, weak toe is involved, foot is involved, cellulitis, and also leg is also involved, extending, and also the fever of 1 week duration. That history clearly tells you that this infection is a life-threatening infection. This infection is increasing in its severity. So don't use OHS in any acute infections. So stop OHS and start using insulin. Which insulin you use here could be a regular insulin, maybe 3 times a day, and proper. And then if the fasting blood sugar is very high, may say more than 200, you have to use the basal insulin also at the vet. So 4 shots a day. That is a basal bolus therapy is very, very important for her to save the life. She was diagnosed to have uncontrolled diabetes with cellulitis of the leg and sepsis of the foot. Treated with insulin along with OHA. My suggestion is stop OHA, start insulin. Antibiotic based on the cultures, good. Her fever subsided, swelling discharge decreased, diabetes status and ulcer foot controlled, discharge with OHA and other supportive measures. So don't hesitate to initiate the insulin during sepsis of any reason. Metabolic control, monitor the blood glucose at least 4th hourly. So you need not go for the 4th hourly, at least 4 times a day. Say fasting blood sugar, pre-lunch blood sugar, pre-dinner blood sugar, and bedtime blood sugar. And adjust the doses accordingly. So the fasting blood sugar, adjust the basal insulin. Suppose the pre-lunch blood sugar, adjust the pre-breakfast regular insulin. And then the pre-dinner blood sugar, adjust the dose of the pre-lunch regular insulin. Bedtime blood sugars, adjust the dose of the pre-dinner regular insulin. That's how you have to treat. Don't go for the 4th hourly blood sugar estimation. Maybe 4 times is sufficient. In patients on OADs, switching over to the insulin injections will be needed in most cases. Increase the insulin doses to cover the persistent hyperglycemia. At the same time, reduce the insulin dose provided the patient gets hypoglycemia. So depending on the hypoglycemia or hyperglycemia, adjust the dosages. Maintain adequate fluid intake. That is very, very important. So most of our people, when they are in a fever or when they get any sepsis, they don't take anything. Even water also they take very little. So that is very, very bad in our sepsis patients. Give adequate fluid intake. That is very important. Otherwise, dehydration. This is the flow chart on the care of a patient with suspected diabetic foot infections. Diabetic foot infection suspected, clinical examination for neuropathy, angiopathy or infections. Limb or life-threatening? No. Give the oral antibiotics and podiatry. That is a simple answer. Suppose if the life-threatening or the limb-threatening, yes, then hospitalize. That is very important. So a lot of people know they don't obey our orders. We request them to get admitted. No, my house is in front of your hospital or back side of your hospital or very near to your hospital. I come morning, evening, afternoon, etc. No, that is not good. Okay, hospitalization. Team approach care. So you should act as a team. Okay, that is very important. Obtain the foot radiograph. That is very important. X-ray and the clinical evaluation. Vascular insufficiency. Yes. So definitely get the vascular surgery, consultations or revascularization procedures. So vascular insufficiency is there? No. Yes. Then the necrosis, gangrene or osteomyelitis. No. So treat with the antibiotics for about 2 weeks. So if they are yes, then the surgical consultation, microbiological workup, blood culture, deep wound culture, bone culture, etc. Debridement or the local amputation. Even the debridement also can be done by you people. Because as a physician, I don't do any surgical work because I'm very busy with the OP. I request my surgeons to do the debridement. For you, you can do the debridement. So that is very small thing. You may not require a MS general surgery to go for the minor debridements. Okay, as a basic doctor, you can do the debridement work. But you should know the surface anatomy. So where are the vessels, how to not to injure the vessels, that is a very important. And then the bone culture is positive, then debridement and short course of the antibiotic therapy, then the guided antibiotic therapy for more than 6 weeks. So all these things can be done by you people. Okay, so the foot ulcer, see the vasculopathy, see the neuropathy, see the angiogram. Okay, even the Doppler studies, and then act accordingly. In the neuropathic foot, severe infection and can lead to the necrosis, which is usually wet. Surgery is almost always indicated here. Neuroischemic foot necrosis is due to the microvascular occlusion and is usually dry. As far as possible, surgery is delayed till the vascular control is achieved. That is what you mean by the wet gangrene and dry gangrene. In the dry gangrene, we wait for that. Necrosis is usually not due to the microangiopathic occlusive disease, small vessel disease. Management of the necrotic foot, surgical options for the necrotic foot, operative surgical debridement, facilitated auto amputation, a larval therapy used in the West. So they put some larva in the diabetic foot ulcers. That larva will eat all the debris, and the wound will be healthy. But we know we are not doing such therapies, larval therapies. Aim for the tight glycemic metabolic control in every care. Psychological aspects. This is also very important. Depression is common among the patients with the diabetic foot and also with the doctor who is practicing the diabetes when they are dealing with the diabetic foot ulcers. We also sometimes get depression. Prolonged hospitalization, quality of the life issues, economic constraints, and trauma of the amputation, maybe the physical and psychological. So hence it's extremely important to offer the psychological support. Role of the clinical. Here also you as a diabetes should act as a clinical psychologist. So don't expect all these people will enter into your chambers or in your hospital. Okay. So sometimes you have to act like a clinical psychologist by sitting with the patient besides. Okay. And take care of. So this is very, very important. Tissue engineering for the wound care. Use platelet derived growth factors. PDGF appears most promising. See, these are very costly ointments are available. Okay. So I don't think that they are very much useful for most of our diabetic foot ulcers, because by the time they approach you, so lot of the pus and etc. So very little role for these PGDFs for a routine practice. Footwear interventions, therapeutic footwear to offload the pressure. Soft and comfortable padded slippers. Use the chappal sandals with the back strap, even in the house also. So all the diabetic foot ulcers, they should be on 24 hours on the chappals. Maybe not 24 hours, maybe 18 to 19 hours, except the bedtime. So most of the time they should be on the slippers. Padded socks has been shown to reduce the pressures, but they have to wash the socks at least once alternate days. So some people they use the same socks for about 1 week, 10 days, and that could be the another reason for their onset of the foot ulcers. Usually made with the microcellular MCR rubbers and MCP rubbers, etc. Custom-made footwear is very, very important. Plantar pressure distribution must be measured to design a custom-made footwear. The shoe can be made with the midsole pressure relief plugs, rigid rocker bottom soles, extra depth with the flat insoles, orthosis like patellar tendon bearing brace. So these are all custom-made footwear. So when I visited the CMC Vellore, I worked as an observer. I was working in the department of the endocrinology there in CMC Vellore. So they have the custom-made footwear, very big hall. Every day they made nearly 500 to 1000 footwears. Very big department, endocrinology, especially the foot care. So custom made. So every patient, whenever they get the chronic ulcers on the grade 2, etc., immediately the podiatrist will come. And then they take the shape of these foots. And then they made the footwear. Within 1 hour, 2 hours, they give you the chappals. By the time they get the lipid profiles or HbA1c, etc., again the new set of the footwear also entered into your chamber. So these are very, very important. Custom-made footwear, because that is the most important rather than your prescriptions. Because offloading is very important. See, offloading is very important. Otherwise, whatever the prescriptions you give it, without you concentrating on the offloading, again the pressure will be there, and definitely the patient will get another infections, etc. So as I told you earlier, the most common cause of foot infection is past history of the foot infection. See, these are all the MCR and MCP, etc. 10 commandments of the diabetic foot care. So this is very important. So the first one is do not walk barefoot. So this applies to all people, all devotees. Inspect the feet daily for blisters, wounds, bleeding, foul smell, increased temperature at the pressure points of the feet. So that inspection of the foot is very important. Do not apply hot fomentation, cold compress, electric heating pads, strong counter irritant ointments to the legs and the feet. So turmeric oils, etc., etc. They apply a lot of the things before they reach you. So provided if you don't tell anything about the diabetic foot. So don't apply these. This is very common in our routine practice in our areas. Use correct footwear. Choose your footwear after consulting your doctor. Always wear the footwear with the socks with loose elastic. So don't order the footwear in your Amazon, etc., etc. Okay, always go to the shop and then wear yourself. That is the correct footwear. Okay? Do not walk wearing weight on the affected foot in case of the presence of the wounds or after surgeries. So these are very important. Do not sit crossed legs for the long time. This is very, very important. So crossed leg sitting is very, very dangerous for the diabetic foot ulcer. Do not remove the footwear during the travel and place your feet on hot subjects. Silencer. This can cause. This is a very common cause of the foot ulcer in our areas. So most of the times, now they are not using the scooters. They are using the motorcycles. Now the silencer obviously get heated, and definitely the foot, the diabetic foot, when they sits, so definitely they get injured, and then most of the times that is the reason for the foot ulcers. Cut the nails regularly. Nails should cut straight across. Do not cut corns or calluses with the blade or the knife. Home surgery is always dangerous. Clean the feet twice a day with soap and water. Wipe the web spaces dry and apply softening agents to the feet. I think these are the most important part of our today's talk. The 10 commandments. So please tell all these 10 commandments to all your diabetics not when they are having the diabetic foot ulcers, before they get the diabetic foot ulcers. So in the initial days of your practice, in the initial days of the patient encountered to you, so please talk on these 10 commandments of the diabetic foot ulcers. Do not walk barefoot and etc. inspection. These are very, very important. Again, the home surgeries. Okay, nail cuttings, and then applying all the material over the ulcers. These are all very, very dangerous. So strategies for saving the diabetic foot: correction of the vascular risk factors, improve the circulation, regular foot inspections, treatment of the foot ulcers, prescribing the special shoes, that is very, very important, teamwork among the medical disciplines, and finally the patient education. So in conclusion, early diagnosis, proper evaluation, management of the diabetic foot, and leading to the reduction in the amputation rates. I think before the early diagnosis, education. So medical education, then early diagnosis, then the proper evaluation, management, and finally reduction in the amputation rates. Thank you very much for your patient hearing.